2 diabetes. DAPA, glycine plus metformin in uncontrolled type 2 diabetes. So let us see the experience that's unexplored type 2 diabetes. So diabetes in India is the recent update 2023 from Anjana et al. From Chennai, Dr. Mohan's Diabetic Center. So Lancets, an Indian healthcare burden, nearly 11.4% the prevalence of the diabetes, and if you take the pre-diabetes, it is about 15.3%, and if you see the incidence rate, it is about the 9.6% right now. So maybe it's a 2023, so you can add 0.1 or 0.2 to this 9.6, maybe 9.7 or 9.8 is the right figure right now in India. So if you take 140 crores of the Indian diabetics, so you can imagine the number of the diabetics in India right now, maybe 12 to 13 crores. Estimated incidence nearly the 10.9% by 2045. But whenever you see the diabetes incidence in India, we are reaching this figure at least one decade earlier. So you can reach by 10.9 by 2030 or 2035 also. That is the exponential growth of the diabetic population in India in a tsunamic proportion. These are the states of India with high prevalence. And if you see the Andhra Pradesh, Telangana and Orissa, it is about 7.5 to 9.9% prevalence. And whereas other southern states, Tamil Nadu, Pondicherry, Kerala, Karnataka, Maharashtra, even the Chhattisgarh, see Punjab, Chandigarh, Haryana, etc., they are the more than the 10%. And if you see the Uttar Pradesh, that is the only state in India with the lowest incidence of the diabetes to the tune of less than 5%. So what are all the challenges in the diabetes management? So the most important challenges we face poor glycemic control. So a lot of our type 2 diabetes, their fasting blood sugar will be high, the postprandial high, HbA1c is very high. That clearly shows that most of our people are poorly controlled blood sugars. And then the presence of the complications and the comorbidities. 40 to 50% of our people with the type 2 diabetes, they present with the complications at the time of the diagnosis itself. So that is the reason a lot of the diabetics in India being diagnosed by the other specialists. Say ophthalmologists are diagnosing the diabetes because they present to the diabetic retinopathy. In the same way, the surgeons will diagnose the diabetes because of the uncontrolled diabetic foot ulcers. In the same way, other specialists also will come to the diagnosis point of view because of the presence of the different complications. Yes, comorbidities. See, in India, only 5 to 10% are the pure diabetics. 95% of the diabetics are diabetes plus hypertension, diabetes plus dyslipidemia, diabetes plus obesity, diabetes plus smoking, or diabetes with CKD, etc. etc. So these are all the comorbidities. That is the reason while treating the diabetes, we have to concentrate on the A, B, C, D. A stands for diabetes, B for the blood pressure, C for the cholesterol, D for the diet and the other drugs and other diseases like comorbidities. Hypoglycemia is a big challenge in diabetes. So we use the anti-hypoglycemic agents like insulin or sulfonylurea. So a lot of the people they present with the hypoglycemia. You should know what is the type of the hypoglycemia the person is getting, whether it is adrenergic hypoglycemia or neuroglycopenic hypoglycemia. Adrenergic hypoglycemia is good because it gives some symptoms like palpitations or perspiration or hypersweating or severe headache or wants to eat something and they correct the hypoglycemia by themselves because they are conscious. Whereas the second type of the hypoglycemia, which is very dangerous, is neuroglycopenic hypoglycemia or hypoglycemia unawareness. They present with a fall on the ground, they present with a froth in the mouth, they present with the convulsions and sometimes a deep comatose also. So this is because of the severe hyperdiabetes, a chronic diabetes with autonomic dysfunction, with a cardiac autonomic neuropathy. So in such people, the sudden cardiac death is very much possible. So that is the reason in such individuals with neuroglycopenic hypoglycemia, don't achieve the HbA1c of 6.5 or 7. Keep the HbA1c at 7.5 or the 8 with a fasting blood sugar more than 125, postprandial more than 200, 225. Otherwise, you are killing this patient much prematurely because of the potentiating of the cardiovascular complications. Non-adherence to the medications is a very, very common, including the doctors, because non-adherence is a big factor for our population maybe because of the clinical inertia, maybe because of the therapeutic inertia, maybe the physician inertia or the patient inertia, or maybe the cost factor. So these are the different reasons for your non-adherence, and then the difficulty in optimizing the outcomes. See, poor glycemic control is a very common challenge in our population. 33% of the type 2 diabetic patients initiating the metformin monotherapy eventually reported the loss of the glycemic control. We all know that metformin is the initial drug to be added or used in all the type 2 diabetes unless otherwise contraindicated. Fine. After initiating insulin or metformin, the blood sugars will come down, but they may not last for the so many years. See, next 3 years or the 4 years or 5 years, again the blood sugars will go up. That means intensification of the treatment is very much needed. You may start with the metformin, but definitely they need the second drug. And you may continue with the double drugs, but they may need the third drug, maybe the fourth drug, maybe the insulin. So it is always a dynamic disease. It is a progressive disease. So we have to upgrade the medication in all our type 2 diabetic individuals. See, suboptimal glycemic control in Indian patients. So we are the different from the Western population. See, our average HbA1c is 8.56. Earlier it was 9.2. So very happy to see this figure less than the 9%. So most of our people, their A1c is around 9%. That indicates that lot of our people will have a lot of complications. So our goal is 6.5, but that will be reached by only 5 to 10% of our population. See, average is 8.5. So a lot to be done in India. So definitely to reduce the A1C at 6.5 or 7. What is our average fasting blood sugar? 172. Our goal is around 100. What is the average PPG in our Indian diabetics? 253. Our goal is 140. Because 141 and 199 postprandial, you consider as a pre-diabetic or impaired glucose tolerance. That impaired glucose tolerance, IGT, itself is a big risk factor for the cardiovascular diseases. It is an independent risk factor for the cardiovascular diseases and the heart failure. So these are the average figures in our Indian population. So you all agree with me that we have to intensify our medical management of the diabetes to reach your A1C around 6.5, fasting blood sugar around 100, postprandial around 140. Why? What are the reasons for not achieving the targets? It's a clinical inertia, time to reappraise the terminal. See, one thing is very clear that we are treating the asymptomatic disease. So the most common symptom in diabetes is asymptomatic. So it is very difficult to treat the asymptomatic individuals. So the failure to advance the therapy. So definitely I told you that we have to upgrade our medication in all the diabetic individuals as the duration of the diabetes is increasing. So the clinical inertia is nothing but the delayed treatment intensification leads to the prolonged hyperglycemia. So what will happen if you delay the treatment intensification? So a lot of the people they present with the complications. So the clinical inertia needs to be minimized and glucose lowering treatments changed more promptly. So let us discuss a commonly encountered case scenario. Here a 62-year-old male, a known diabetic for 22 years, visited an endocrinologist for the management of his uncontrolled hyperglycemia. He is also an hypertensive, is obese and ex-smoker. And A1C 1 week ago was 9.3. So such cases we often see in our routine practice. So the diabetic of more than 20 years duration. So that means he got the diabetes at the age of 40 years. Okay. So not only the diabetes, he is also an hypertensive. He is obese. He is an ex-smoker. So we don't know the duration of this cessation of the smoking. Suppose if the smoking cessation is only 2 years or 3 years, it is also a big risk factor for your cardiovascular disease unless there is a period of more than the 10 years or the 15 years. See the A1C level is 9.3. 9.3 is a very high. 8 years ago, A1C was 8.2. 3 years ago, it was 9.1. Now it is 9.3. With a poor glycemic control, no weight loss despite the diet and exercise. So this is a very commonly seen cases in our routine practice. A lot to be done to this patient. Not only your drugs, your dietary approach, your modification of the diet, your additional of your reduction of your simple sugars, complex carbohydrates, more and more protein, and less saturated fats, no trans fats, more polyunsaturated, monounsaturated, more fiber, less salt, So these are all the, and more fruits. So these are the different dietary advices you have to give to these patients. And then the physical activity. So the physical activity for about 60 minutes a day, uninterruptedly 7 by 7 or 365 by 365. That should be the your exercise schedule for all our uncontrolled type 2 diabetes, because insulin resistance is the main reason for our Indian diabetes. Unless these people are on good dietary approach and exercise, so whatever amount of the OHS of the insulin you prescribe, so the reaching your HbA1c target of 6.5 is very, very, very difficult. So always advise diet and exercise. So number one for all the diabetic treatment is, number one, not your drugs. Number one, diet. Number two, exercise. And then there's maybe some yoga or maybe the meditation, and then only your treatment, your drugs. See here, the blood pressure is 156 by 90. So all the diabetic individuals, not 140 is not your target, maybe 130, maybe 120 also. So your target should be less than 130 in all the diabetics, if not 120. If you reach 120 without any hypotension, that will be the best systolic blood pressure the patient should have it. So the diastolic is 90, is an hypertensive. So your target is 85 or less than the 80. BMI in 32, 32 is a very high. So the normal BMI for us is the 23. So 32 is a very obesity. Waist circumference 42 inches. So the males, it should be less than 36 and females less than 34. So 90 centimeters in the males and 80 centimeters in the females is the waist circumference. For Indians, I think waist circumference or waist hip ratio is much more important than the BMI, because we are having the abdominal adiposity. So this abdominal adiposity, the visceral adiposity, is more dangerous and more atherosclerotic. So if you take the BMI, BMI may be 23. So you are happy. The BMI is 23 is a normal BMI. But if you see the waist circumference, it is 95 centimeters. That means this is much more dangerous and this is much more atherosclerotic. Chest is clear, sounds of the normal, no pedal edema. So the fasting 194, PP 268, A1C 9.3. So how to treat these patients? So it's not, see at this juncture, it is very, very difficult to treat with the metformin alone, or metformin plus gliptin, or metformin plus dapagliflozin. So at least 3 or 4 OHs are required at this juncture. And sometimes you may add the basal insulin also in these patients to control the fasting blood sugars very effectively. So this patient requires definitely the polypharmacy, maybe the 3 or 4 OHs, or maybe the 1 basal insulin. See, these are the consequences of the obesity and the type 2 diabetes. See, for all diabetic individuals, they should maintain the ideal body weight. Just 1 kg more than the weight, normal body weight, definitely leads to a lot of the complications, maybe 30 to 40% increase the risk of these complications. See, the obesity, definitely there will be the increased insulin resistance, and there will be the glucose intolerance. Obesity increases your blood pressure. Obesity increases your inflammation. This is a vascular inflammation. High sensitive CRP will be more than the 3. Some people will have the 9, 10, etc. Dyslipidemia. So the diabetic dyslipidemia. There will be hypertriglyceridemia. There will be low HDL. And LDL could be the normal, but it is a small and dense LDL. They are more atherosclerotic. This is very common in our diabetic obese individuals. Endothelial dysfunction and erectile dysfunction. So the 2 EDs in diabetes. So endothelial dysfunction is more atherosclerotic, and erectile dysfunction is also more of cardiovascular disease, type 2 diabetes. There are the different risk factors, not only these, obstructive sleep apnea, the snoring, or maybe the sleep disturbances, sleep deprivation, or non-dipping of the blood pressure during the night. So these are the very common in our obese individuals, and cholecystitis, gallstones, osteoarthritis, gastroesophageal reflux disease, okay, constipation. So these are the different consequences or the complications of the obesity in our diabetic individuals. So the outcomes, these are more prone for the cardiovascular events, coronary artery disease, maybe the single vessel disease, double vessel disease, triple vessel disease, or 4 vessels, and finally they may require the bypass. Heart failure is a very, very common. Arrhythmias, both the bradyarrhythmias and the tachyarrhythmias are very common in the diabetic obese individuals, and sudden death is also possible because of the autonomic dysfunction and arrhythmias. A1C thresholds indicating the high risk of the both micro and the macrovascular complications. So the more the A1C, the more the complications. This is the cardiovascular disease consequence of the delayed intervention. So they don't delay the intensification of the treatment. So this is called the metabolic memory. See, you have the two patients. One patient with HbA1c more than the 7% here and less than the 7%. See, more than the 7%, less than the 7%, there is a gap here. So at 5.3 years, significant increase of the MI, stroke, heart failure, etc. See, this is the legacy effect. So the legacy effect is nothing but you have to identify the diabetes at an early time and you have to control the diabetes very effectively. And if you control the blood sugars effectively from the diagnosis itself, these people will not have the complications at a later time. On the other hand, if you don't control the blood sugars effectively in the initial days, even though the control is good afterwards, these people are likely to have more and more complications in the near future. So, diagnosis of the diabetes much early and then intensification of the diabetes management is also very important to avoid the long-term complications. So, let us discuss another commonly encountered case scenario. Here the case with the CKD. So, last time my friend in the same dais, he told that CKD means C for cardiovascular disease, K for kidney, D for diabetes. Okay, so this is the CKD in the diabetes. Now the CKD is associated with the diabetes mellitus. Yes, diabetic kidney disease affects nearly 1 in 7 individuals worldwide. 25 to 40% of the patients suffering from type 2 diabetes and may be present at the time of the diagnosis of the diabetes. So I told you that 40 to 50% of type 2 diabetes, they present the complications at the time of the diagnosis itself. So after you diagnose the diabetes, if you check the UACR, urinary albumin creatinine ratio, that will be more than the 30. Some people will have 300, 400, 500. And if you check the creatinine levels, maybe 1.5, 2.5, 3.5. Some people will be having the 7, 8, 9 asymptomatic. So these are the very common. That means that he must be having the diabetes for the last how many years. Now presenting with the diabetes and CKD. Again, the common symptom in CKD is again no symptoms at all, asymptomatic till they reach the stage 4 or the 5. Most of the people in diabetes were diagnosed at the stage 3 or sometimes the stage 4 and the 5 also. So unless you check the urine albumin creatinine ratio or the urine microalbuminuria, unless you initiate on the ARBs or the ACE in all the diabetic individuals, so we are inviting the CKD in most of our diabetic individuals. Here a case about 65-year-old female, a postmenopausal woman, diabetes. For her diabetes, she visited the diabetic clinic, a mild exercise intolerance and a minor lower leg edema since 5 months. 5 months, sorry, 5 months. See, exercise intolerance is always mild and lower leg edema is also mild. So most of our Indian patients, they come only with the moderate or the severe dyspnea. So by the time we diagnose it, the patient is already in the pulmonary edema or the JVP is elevated or bilateral pedal edema or maybe the hepatojugular reflex. So in such situations, we very commonly seen, but we have to identify these people at a lower stage or initial stages only. So she's a diabetic for the last 80 years on metformin therapy, also hypertensive, controlled with ACE inhibitor and a diuretic, and she is hyperlipidemic since 5 years and atorvastatin 20 milligrams. See, the patient at the age of 65 years, a diabetic, hypertensive, dyslipidemia, postmenopausal, and now with the symptoms. She has a stent placed, so already PTCA, past history of the PTCA 3 years ago, and antiplatelet agent clopidogrel. Lower extremity edema and diuretic 10 milligrams daily. No headache, nausea, visual changes, weight fluctuation, chest pain, or sharpness of the breath. These are also negative symptoms are also very important in our diabetic management. So sometimes when the patient is complaining of the pedal edema, you have to ask all these questions like breathlessness, or the chest pain, or abdominal distension, or urination, or defecation, or sleep disturbances. So these are also very important. So if the patient says yes, 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 all these symptoms, so the patient is at high risk. See here the blood pressure is 122/64, excellent control. Heart rate 64. See, in all the diabetic individuals, please consider the heart rate also. So tachycardia normally is more than 100. In diabetics, it should be 90. So more than the 90, you have to act. Otherwise, these people will have lot of the cardiovascular consequences at a later time. So here the BMI is 25, that is overweight in Indian standards. CNS examination is normal, perabdomen is the normal, etc. See here the blood sugar, fasting 155, postprandial 180. Here, if you see the fasting and the postprandial, fasting is much more when compared to the postprandial. So that indicates that hepatic glucose output is more in these individuals. Luckily, she is getting the metformin, which acts very good at the level of the liver. But here, you have to increase the metformin or you have to add other drugs to tackle this fasting blood sugars very effectively. Here, the A1C is 8.7%. So that means still you can add some OHs. See, at the A1C, say beyond the 9, textbook says that Western population, so there is a room for the basal insulin therapy. Whereas in India, we can wait till the HbA1c of 10 or the 11 is 12 also, provided the patient is asymptomatic and not having any asthmatic symptoms. But in such situations, along with the metformin, you can add some other drugs with HbA1c of 8.6, 8.7. Here the creatinine is 1.3. So don't be happy with the creatinine alone, get the GFR done. That is a very, very, very important in all the diabetic individuals. Even though creatinine is 1.3, if you check the, calculate the GFR, it may be 34 or maybe the 45. So that means already the patient is in the stage 3 CKD. Blood urea, nitrogen, calcium, albumin, they are the normal GFRC the 49. So GFR 49 means already stage 3. Urine albuminuria, C1 or 2. It should be less than the 30. So this patient is a diabetic, hypertensive, dyslipidemic, obesity, overweight, and now she is in renal failure, CKD. CKD, the two factors to say the CKD here is proteinuria and also the GFR. So if you see the heat map, I have given you on the earlier talks. So if you see the heat map, so on one hand you have to put this proteinuria, on the other hand you have to put the GFR. So the risk. So most of these people are at high risk. If the proteins are there and the creatinine GFR is low, that means very high risk individual you are dealing with, even though the patient is asymptomatic. So as per the kidney disease improving the global outcome guidelines, this patient has high risk kidney disease at stage 3A, uncontrolled diabetes mellitus at 8.7 things. So these are all the different guidelines. All the guidelines, you take any Indian guidelines or ADA or Europe or Australia or Canada, all say that all the diabetic individuals is be careful. So check all the necessary investigations and act accordingly to give them good quality of the life. Now our aim is glycemic pentad. Earlier, glycemic triad. So triad means control fasting, control PP, control A1C. Now the pentad. Pentad means fourth one is glycemic variability or time in range, etc. And the fifth one is the quality of the life. So these are very, very important in our diabetic individuals. Another case, about 59-year-old female, 6 months history of the worsening the shortness of the breath and exertion and associated ankle swelling. So she got dyspnea with swelling of the feet. So most probably a heart failure. See, 10 years history of the type 2 diabetes. Prior myocardial infarction followed by the coronary artery bypass graft surgery 3 years ago. So at the age of 59 years, 10 years history of the type 2 diabetes, and 3 years back, she underwent bypass. Now presenting with shortness of the breath and the fatal edema. Dyslipidemic and also uncontrolled hypertension. See the scenario. She is a diabetic, she is an hypertensive, dyslipidemia. So IHD, CABG 3 years back, now presenting with heart failure symptoms. She is on aspirin, rosuvastatin, metoprolol, must for all the IHD patients. So the post PTCA or post CABG, beta blockers are the must. Whether you use metoprolol or use bisoprolol or use carvedilol or you are a Nevistar or a Nebulol, but beta blockers are the must because beta blockers are the compelling indication to use the diabetes in the presence of cardiac diseases. Metformin 1000 milligrams once daily and glimepiride 2 milligrams once daily. So she is on polypharmacy for some drugs for the diabetes, some drugs for the cardiac, statins and aspirin, etc. See the general examination BP 166/98. So post CABG, diabetic, hypertensive, dyslipidemia 166/90 is very, very high. So in the context of the patient, you should see that don't give the loose that 166/90. No. So a lot of people will have blood pressure 180/100 or 200/110 like that. See 166/98 in this background, is as equivalent as 300 by 200. So I have to give a lot of respect to the blood pressure in all the diabetic, complicated diabetes, because presence of the hypertension will aggravate all the complications of the diabetes, whether it's microvascular or macrovascular. So our aim, our goal of the blood pressure in this particular patient, post CABG, diabetes, hypertension, dyslipidemia, etc., it should be 115 by 75, provided if the patient is not having any hypotension symptoms or giddiness or vertigo, etc. So your goal, if not 115 by 75, at least 120 by 80, or at least 125 by 82, or at least 130 by 85. That is our goal. So here 166 and 98 is a very, very high. See, heart rate 75 beats. So I have to improve the beta blocker therapy here. So there is a room to improve your beta blocker therapy. So you have to keep the heart rate around 50, between 50 and the 60 in all the post CABG or post PTCA patients. So the more the heart rate means, again, more the chances of having early heart failure. Here the BMI is 38. So moribund obesity, 38 BMI is. So the pitting edema of both the ankles. Here the respiratory bibasal crackles on the aspiration, on auscultation. So that means you are dealing a case of left ventricular failure and right ventricular failure, biventricular failure. Here the GFR A1C is 8.3, GFR 58. So stage 3. Creatinine 1.1. See, if you see the creatinine is 1.1, but if you calculate the GFR for her, it is 58, already stage 3 CKD. Urine albumin creatinine ratio 940, normal is less than 30. So she got proteinuria, she got elevated, reduced GFR, so she is in stage 3. See the cholesterol. So the total cholesterol 234, LDL 156. So in all these high risk individuals, your goal of LDL is not 70 or the 100 or 130. It should be around 30, between 30 and 55. So the lot of studies now say that in high risk individuals, in all the diabetics, CAPD, etc., so you have to keep the LDL between 30 and 50. Okay, so 156 LDL cholesterol is a very, very high for her. So don't be happy with the 10 milligrams of your rosuvastatin. You have to go up to the 40 milligrams of the rosuvastatin or 80 milligrams of the atorvastatin. And you may add the HTMF also along with your rosuvastatin. And some people you may add the bempedoic acid also to these populations. So again, a polypharmacy for your lipids management is also required this patient. And if not, sometimes you may use the PK. What is that? PKC, PK. Yes. So the monoclonal antibodies for the lipid management, PKCD, I think. HDL-C cholesterol, see the 38. So in females, our goal is 50. Triglycerides 200. It should be less than the 150. See NT-proBNP, it is very high, elevated 700. So if you see these figures, they looks like so normal, just abnormal. And if you combine all these abnormal figures, so this patient is very, very high risk individuals. So echo, a normal left ventricular systolic function. So your ejection fraction is 55. That means normal means more than the 50. So 60. So don't be happy with the only EF. Even though the EF is the normal, here you have the mild diastolic dysfunction. So that means the patient is in the heart failure with PEF. That means preserved ejection fraction. Suppose if the left ventricular ejection fraction is 35 at the 40, that means heart failure REF, reduced ejection fraction. So even though the EF is here the more than 50 or 55, this patient is in heart failure. So heart failure PEF with mild diastolic dysfunction. So the areas of concern in this patient is you have to keep the HbA1c from 8.6 to here, and you have to reduce the blood pressure, you have to reduce the body weight, and you have to reduce the heart rate, and you have to reduce the cholesterol. So these are all the very, very important things to be done in this particular patient. See, I already told you the hypoglycemia, 2 types of the hypoglycemia, adrenergic and neuroglycopenic. I don't want to spend much time on this hypoglycemia, even though this is the most common acute complication of the diabetes. So whenever you ask any undergraduate student, what is the most dangerous complication of the diabetes? It is not DKA, or it is not HSS, or it is not lactic acidosis, or metabolic acidosis, etc. It should be hypoglycemia. So even today, the most common cause of the death in elderly individuals is hypoglycemia. So, but most of the people, their attendants, they say that the patient, that fellow is in profuse sweating and etc. We thought that it could be acute myocardial infarction. See, most of the deaths, elderly diabetes is because of hypoglycemia, not others. Non-adherence to the medications a common concern. Risk increases with the number of the medications on higher dosing. This is also very important. Polypharmacy is very much needed for all the chronic diabetics, but at the same time, drug-drug interactions, these are all very much there. So you should know which drug should be given before food, which drugs should be given after food, which should be given at any time of the day, and when to give these aspirin, when to give your clopidogrel, when to give your statins, when to give your ARBs or ACE inhibitors. So these are all very, very important drugs to be given for all our population. And again, you have to check the potassium levels. Very, very important in our chronic diabetes in high risk individuals. So according to your potassium levels, you have to adjust these drugs. Because on one hand, this patient is in the CKD. On the other hand, the patient is also having a uncontrolled diabetes. So, and also hypertension, use ARBs, etc. So by using these ARBs and in the presence of the CKD, it's a potential candidate to have the hyperkalemia. So the potassium levels are very, very important here. Linked to the hypoglycemia, increased cost, morbidity and mortality rate, and ranges from 30% to as high as 100%. What is 30% to 100%? Non-adherence to the medications. Even today, we see a lot of the population that they miss the drugs. They miss the drugs because of the non-adherence. 30% to the high 100%. See, optimizing treatment goals in the diabetes, heterogeneity of the patients. See, one size fits all is not there in diabetes. Even the twin brothers, same weight, same height, see, same date of birth, the treatment differs. So we have one twins in our friends, Lakshmoji and Ramoji, Lakshmoji Naidu. So he's an ophthalmologist, and his twin brother is a retired electrical engineer. So both are the diabetics. The treatment is totally changed. One fellow got CABG 12 years ago. Another fellow got CABG just 1 year ago. See the difference. See, so that means that in diabetes, one size fits all is not there. And individualized care. So every individual is different. So we have to give an individualized care to these patients. And so a lot of our people have the multiple risk factors. I told you ABCD in diabetes management. Diversity in the patient responses. Some people, even with 1 milligram of glimepiride, the people develop the hypoglycemia. And I have seen some prescriptions from our Kakinada diabetologists. Glimepiride, they use 4 milligrams BD and TAD also. 4 milligrams BD and TAD also. Okay, so they don't get in hypoglycemia. That means that the drug is not at all working. So the diversity in the patient response is also there. See, some people know headache, well controlled with your aspirin, paracetamol. And another fellow headache will be controlled by your naproxen. Another fellow's headache will be controlled by taking some alcohol or some rest or sleep. So these are different. So we see a lot of these people. So the diversity in the patient response. Some people, like clever people, they say that doctor garu ఎన్ని drugs ఇస్తున్నారు headache తగ్గదండి. Just Dolo చేసుకుంటే సరిపోతుంది. They're happy. Good. So Dolo is very, very good molecule to reduce the fever, to reduce the body ache, to reduce the headache, etc., etc. So the lack of the clear evidence. Even today, that is the beauty of our medicine. So what is right today may not be right tomorrow. So still there are a clear, say what I can say, some gray areas. That is the right word. So there are some still gray areas are there in the management of the diabetes. Still we don't know what we are supposed to do in some of our patients. See, the long-term outcomes are very, very important. So a lot of the people say that no sir, this drug works wonders. I have few patients and it's very, very good. So that's not right, and don't consider such words. Always long-term outcomes are very, very important in our diabetic management. So the benefits of intensive glycemic control, already told the legacy effect. Undertake any trials. Intensive treatment is always better. See, the 1% reduction in your HbA1c reduces the microvascular and macrovascular complications. Micro to the tune of 38%, macro to the tune of 16%. So to reduce the microvascular complications, diabetes control is sufficient. Whereas to control the macrovascular complications like your heart attacks or your CVD, not only the diabetes and others also needed, like blood pressure, dyslipidemia, etc. So intensive A1C control prevents the kidney-related complications very well. Legacy effect, I already told you. Of earlier glucose control, you have the major benefits. impact of early and the late intensification of the glucose lowering therapy. If you control the blood sugars very early, so this is the benefit. This much is the benefit in A1C reduction. So late intensification, very poor control. Combination therapies. So if you see any guidelines, so now the diabetes is treatment is individualized. So when the patient is sitting before you with the diagnosis of the diabetes, you think that whether the fellow is at risk of atherosclerotic cardiovascular disease or at risk of CKD or at the risk of heart failure, whether the patient is obese or any hypoglycemic attacks are there or not. So these are the important indications to start which drug to be started in most of our population. So in all these individuals, metformin can be used, and after the metformin, SGLT inhibitor and the gliptins, now they are gaining up. Whereas in India, where the A1C, the average A1C is up to 9 or the 10, there is always a role for the sulfurias to be used in our population. So that is the reason sulfurias are still one of the important drugs to be used in our Indian diabetic individuals. See, the combination therapy, dual combination therapy is always there in our diabetic management, like your tuberculosis or in HIV or in hypertension. Same in diabetes also, not a single drug, monotherapy. Monotherapy, only 5% of our diabetics. So when your target goal is more than 1.5% of your goal, so our goal is 6.5. Suppose if the patient presents with the 8, so definitely the combination therapy. Our average is more than the 9. So definitely, lot of our people, they need the combination therapy. So the drugs in combination act by the different mechanisms. I told you what you mean by the homogeneous octet. So you have to tackle the alpha cells, beta cells. You have to give some drugs about the intestines and some drugs on the kidneys, some drugs on the brain, and some drugs on the intestines, incretins, etc. So if you combine these drugs, they act in the different mechanism in a synergetic way. You can control the blood sugars very effectively. But don't give the 2 sulfonylureas or 3 sulfonylureas in a single patient. So SGLT inhibitors, beautiful drugs. So we all know that it's not a myth and a miracle. So the SGLT inhibitors reduces the risk of MACE, heart failure, hospitalizations, and also the cardiovascular death. They prevent the progression of the CKD because they reduce the proteinurias and they improve the they reduce the intraglomerular hyperfiltration, and then they reduce the intraglomerular hypertension. They reduce the body weight also, blood pressure, significantly reduce the albuminuria. So these are all the advantages of the SGLT inhibitors. So that is the reason it is a cardiac friendly and the renal friendly. Cardio and renal protection greatly improves the quality of the life of the patients and reduces the medical expenses because now it is much cheaper. Earlier, each tablet of SGLT inhibitor is about 90 to 100 rupees. Now it is available at 8 rupees or 7 rupees also. So the guideline recommendations to reduce the cardiorenal risk of the SGLT inhibitors. Patients with type 2 diabetes, high risk of heart failure, should be treated with the GLP-1 receptor agonists or SGLT inhibitors. So now the DAPA plus glimepiride plus metformin, a beautiful combination for Indian diabetics. Once they present with HbA1c of 9 or 10, without the symptoms. If the patient presents with osmotic symptoms like polyuria, polyphagia, polydipsia, or unintentional weight loss, etc., etc., so the only answer is the insulin. When the patient is asymptomatic but high blood sugars with high HbA1c, then this triple drug therapy is very much needed. So the triple therapy in the diabetes, International Diabetes Federation, now RSDDA. See the primary outcomes. So the triple drug therapy reduces the blood sugars very effectively. A1C reduction. Now the fasting blood sugar is reduced. Postprandial blood sugar is reduced and very effectively with these drugs. And secondary outcome is also good. Reduction in the body weight is also there with your SGLT inhibitors and the metformin. Hypoglycemia. Fortunately, if you combine the glimepiride with the metformin and the sulfonylureas and the SGLT inhibitors, the chances of hypoglycemia are very less when compared to the glimepiride alone. So the combination of the glimepiride with the metformin and the SGLT inhibitors, the chances of hypoglycemia are very, very, very low. So this study concludes that it's a very good drug, very useful drug, very combination drugs with a different mechanisms, a synergetic effect, and finally A1C reduction will be good, fasting blood sugar reduction will be good, postprandial reduction will be good, and then your finally the quality of the life is also improves. So improves the drug adherence. Obviously, you are giving the 3 drugs in a single pill. Obviously, drug adherence will be improved and effective control acts with the different mechanisms and also reduces the pill burden. So what are all the take-home messages? A stepwise addition of glucose-lowering medication generally remains preferred to the initial combination therapy. Insufficient evidence to suggest that first-line combination therapy is superior to the sequential addition of medications to maintain the glycemic control or slow the progression of the diabetes. In patients more than 1.5% above their target HbA1c, initial combination therapy should be considered. That is the reason 95 to 96% of our people, they need a combination therapy. What you mean by more than 1.5? Your target is 6.5. And some of my patients I keep at 6 also. Suppose if the person is about 20 years or 21 years, the diabetes, type 2 diabetes, my target is not the 6.5, maybe 5.7. Why should not? So that is the reason. So you have to use the combination therapy in these individuals, but always aware of the hypoglycemia when you are using the combination therapy. Fixed dose formulations can improve the medication taking behavior when combination therapy used and may achieve the glycemic targets more rapidly. So thank you very much for your patient hearing. And if you have any doubts, I will be very happy to clarify them.